past decade has seen an enormous surge in popularity for products formulated specifically to treat hyperpigmentation and increase the skin's luminosity. While traditionally these products were popular in Asian and African communities, the demand for them has increased tremendously around the world. This can most likely be attributed to an aging global population that is now experiencing years of sun damage combined with fluctuating hormones that ultimately shows up as pigmentation spots on our skin. Fortunately, consumer demand for products to treat hyperpigmentation has spurred both the pharmaceutical and the cosmetic companies to research and develop new technology and products that are not only effective but safe to use. As professional skincare therapists, your focus must also be on seeking out products that are safe and effective for treating the skin without causing irritation or damage, which can lead to premature aging or worse. At the International Dermal Institute, we've not only studied the newest technology for the treatment of hyperpigmentation, but we've updated our understanding of its underlying causes. In today's webisode, we will cover what determines skin color, the causes of pigmentation, how pigment is made in our skin, and what we can realistically do to treat it. Skin color is mainly determined by the amount of melanin present in your skin. Melanin, the brown or reddish skin pigment, is synthesized in dendritic cells called melanocytes. Regardless of race, we all have approximately 800 to 2,000 melanocytes per square millimeter of epidermis. Melanocyte cells look like an octopus with long arms and dendrites extending upward into the lower layers of the epidermis. When we're exposed to sunlight, the pituitary gland in our brain generates a hormone called alpha or beta melanin stimulating hormone, often referred to as MSH. This hormone binds to a specific receptor on the melanocyte, signaling melanin formation to commence. It also triggers an inflammatory and immune response in our skin. Likewise, when inflammatory modulators that trigger an immune response in our skin are set in motion, melanogenesis is also stimulated, which explains why we often see pigmentation associated with inflammation or wounds. To complicate matters further, there are receptor sites on the melanocyte that are affected by estrogen, which accounts for the influence that hormones have on pigment formation. As you can see, our hormones, our immune system, and the melanocytes, they're all interconnected. Regardless of the trigger, once the melanocyte is activated, synthesis of melanin commences. Melanin pigment is contained in a jelly bean-shaped structure known as a melanosome. After the melanosome is produced in the melanocyte, it's transferred to a neighboring keratinocyte cell where it begins its journey through the different layers of the epidermis while contributing to the skin's color. Whether your skin is light or darker, the number of melanocytes does not vary among humans. There's approximately 1 melanocyte cell for every 36 keratinocytes found in the epidermis. So what determines our skin color and intensity? There are 4 factors to consider: the amount of melanin, the type of melanin produced, whether it's eumelanin, a brownish-black pigment, or pheomelanin, a yellowish-red pigment, the size of the melanosomes, and finally, the distribution of melanosomes in the epidermis. All of these factors contribute to the skin's color and intensity. In black skin, we not only see larger melanosomes with more melanin present, but more of them. They are seen as larger individual jelly bean-like structures surrounded by a membrane, whereas melanosomes in Caucasian, Asian, and Hispanic skin are smaller. They vary in size and shape, and they have many melanosomes clustered in a single membrane jacket. While the amount of melanin synthesized in our skin is determined by our genetics, there's also an overriding effect from exposure to UV radiation. Due to its ability to absorb UV radiation, the primary function of melanin is believed to be to protect the cells and skin from sunlight. As you know, when we're exposed to sunlight, melanin synthesis is stimulated, resulting in a characteristic tan. Studies have shown that exposure to sunlight causes melanosomes to actually cluster, forming a protective cap over the nucleus of the cell. In addition to the development of an overall tan, exposure to UV light may also stimulate hyperpigmentation in specific areas, such as our hands, our face, and our neck. These dark spots are often referred to as age spots or liver spots, and they're an issue for both fair-skinned and darker complexions. Age spots usually become evident in our early 40s and become increasingly more evident as we age. By the time we reach 60 years, 90% of us will have sun-induced age spots. Lentigines, the technical term for age spots, are harmless, flat, brown discolorations of the skin, which usually occur on the back of the hands, the neck, and the face of people more than 40 years of age. These spots, more than anything else, give away a person's age. Sunspots are caused by the skin being exposed to sun over many years, and unlike freckles, lentigines do not fade in the winter. Freckles, also known as ephelides, are also flat spots that are red or brown and typically appear during the sunny months and fade in the winter. They're most often found in individuals with fair skin and are generally a genetic trait. Both freckles, ephelides, and age spots, lentigines, look very similar to the naked eye. Short of monitoring their color intensity in the summer versus winter months, the only way to distinguish the two is to look at a section of the skin under the microscope. Lentigines, or age spots, display flattened reed ridges, the finger-like projections that are found at the interface between the epidermis and the dermis, and they have noticeable pigmentation in the stratum germinativum layer. There are also more melanocytes in the region. Freckles, on the other hand, do not show any of these changes to the reed ridges, and they have a normal amount of melanocyte cells. Because light-colored skin has less melanosomes, less melanin, and lower levels of eumelanin than darker skin, there's less protection against exposure to UV radiation. Likewise, the majority of the melanin is confined to the lower layers of the epidermis. In darker skin, the melanin is evident throughout the layers of the epidermis, with more melanin in the outermost layers of the stratum corneum. While it stands to reason that darker skin would be easier to treat due to the melanin being closer to the surface of the skin, the overall abundance of the melanin in dark skin actually makes it more difficult to treat. It's important to note that darker skin, with its greater concentration of melanin, is still vulnerable to sun-induced hyperpigmentation, as well as post-inflammatory hyperpigmentation and photodamage and skin cancer. Let's take a look at some of the other causes of pigmentation other than exposure to UV radiation or sunlight. There are additional factors that can lead to hyperpigmentation, such as medications, diseases, and UV exposure, combined with certain fragrances. But for the purpose of this webisode, we are going to focus on the major contributors. In addition to genetics and environmental influences, skin pigmentation is affected by hormonal factors and wound healing. The latter gives rise to post-inflammatory hyperpigmentation, called PIH. This is a phenomenon that is more problematic for individuals with darker skin color. PIH stems from the melanocytes' exaggerated response to trauma, which results in an increased distribution of melanin in the tissue. Remember, the same inflammatory mediators that are stimulated when the skin's immune response is activated also triggers melanocytes to produce melanin. Fortunately, when inflammation subsides, the inflammatory mediators revert to normal levels, and so does the production of melanin. In due course, the cells causing the hyperpigmentation rise to the outermost stratum corneum and slough off, causing the hyperpigmentation to disappear, as long as the source of the inflammation subsides as well. Recent studies have shown that depending on the depth of the inflammation or the wound, hyperpigmentation can not only be evident in the epidermal cells, but in the dermis as well. This may very well account for the difficulty in treating post-inflammatory pigmentation associated with deeper scar tissues. Hormonally induced pigmentation manifests itself in various forms such as hyperpigmentation spots and melasma, better known as the mask of pregnancy. Melasma affects primarily women of childbearing age. Some studies suggest that up to 75% of women may develop melasma during pregnancy, and about a third of the women on birth control pills will as well. It's more prevalent in women with darker skin color, and it's most commonly seen in areas that are exposed to sunlight. Some scientists say that UV exposure seems to be a requirement for melasma to develop, which may account for the fact that it's less noticeable in winter months when UV exposure is less. Melasma is seen as an irregularly shaped patch of hyperpigmentation, ranging from light brown to dark brown in color. The most common pattern that we see is called centrofacial. This is on the chin, the upper lip, the cheeks, the nose, and the forehead. To a lesser extent, we can see melasma on the cheeks and just the nose, and even less common is what's known as jawline pigmentation or melasma. The name mask of pregnancy points to its frequent occurrence during pregnancy or when oral contraceptives or hormones are taken. It is thought that estrogen and UV light seem to be the biggest culprits in this condition. The hyperpigmentation may be permanent or disappear and reappear with subsequent pregnancies or use of contraceptive pills and hormones. Although melasma is evident during pregnancy, it can also appear as the result of some ovarian disorders. It's believed that both estrogen and progesterone can influence melanocyte activity, driving the production of melanin. When compared to melanocyte activity that is stimulated by sun exposure, hormonally induced melanocytes are considered to be hyperactive. Hormonally induced melanin may be confined to the epidermis, but it may also be found in the dermis, making treatment especially difficult. Once hormonal fluctuations subside, such as the end of pregnancy or discontinuation of hormonal supplements or birth control pills, the hyperpigmentation often disappears. However, the condition may persist for up to 5 years after pregnancy or stopping of birth control pills and hormones. And unfortunately, once you have it, you're more prone to get melasma again. To complicate matters, the melanin may reside in both the dermis and the epidermis, which accounts for why it's so difficult to treat, as treating the dermal pigmentation is almost impossible with a topically applied product. In order to understand how we can effectively treat hyperpigmentation, we need to review how melanin is made in the skin. The process of melanin production is known as melanogenesis. The production of melanin by the melanocyte is a very complicated pathway which starts with a key amino acid called tyrosine. The most critical steps in the biosynthesis of melanin appear to be the first 2 steps that are controlled by an enzyme called tyrosinase, a copper-containing enzyme that catalyzes 2 distinct reactions in the production of melanin. Up until very recently, most of the ingredients that we use to fight pigmentation targeted these very 2 steps in melanin biosynthesis. Once step 2 is completed, the pathway splits and several subsequent reactions lead to either eumelanin, the brown and black melanin, or pheomelanin, the yellow and red melanin pigments. Eumelanin is the brown-black pigment that we find in Caucasian, Asian, and ethnic skin, and it's the most common pigment that we see in the skin and provides the protection that we need from UV radiation. Pheomelanin, the yellow-red pigment that we see in fair skin and red hair, is relatively rare and offers no photoprotection to the skin. The newly formed pigment is then packaged into a melanosome and deposited into a neighboring keratinocyte cell. The most obvious means of controlling pigmentation, especially sun-induced, would be to apply regularly a broad-spectrum sunscreen with a minimum SPF of 15, preferably more like an SPF of 30. This will help control future pigmentation. But what about existing hyperpigmentation? For years, hydroquinone has been considered to be the most effective ingredient for lightening hyperpigmentation. It's classified as an over-the-counter drug in the United States of America and may be used in concentrations of up to 2% by professional skin therapists. While hydroquinone may be an effective pigment lightener, there are many concerns regarding its safety. It's been estimated that 1/3 of the population is allergic to hydroquinone. Serious contact dermatitis has been noted, and skin may be photosensitized with prolonged use. Hydroquinone has been classified as, and I quote, an extreme sensitizer. In some cases, a condition known as ochronosis can result, leading to actual hyperpigmentation and acne-like lesions. The Occupational Safety and Health Administration, known as OSHA in the USA, states that hydroquinone is mutagenic and has cancer-causing potential. The addendum to the final report on the safety assessment of hydroquinone, published in the Journal of the American College of Toxicology in 1994, concluded that hydroquinone is a potent cytotoxic agent that causes mutations and alterations to DNA, and it should not be used in any leave-on type of product. It is safe for rinse-off products when used in concentrations of less than 1%. Remember, most over-the-counter products marketed to lighten pigmentation use hydroquinone at 2% concentration, and they're left on the skin. They're certainly not washed off. Bearing in mind these results of these studies, it should really come as no surprise that the use of hydroquinone has been banned in many countries throughout the world. In spite of all of this, hydroquinone is the only ingredient recognized as a lightening agent by the United States Food and Drug Administration. Consequently, any other ingredient used to lighten skin must be referred to as a brightening agent and not a whitener or a lightener. In the past few years, as hydroquinone has fallen out of favor and even banned in most of the world, there's been an onslaught of alternative brightening agents that are now marketed to combat hyperpigmentation. At the International Dermal Institute, we have studied the various mechanisms that are known to impact melanin formation. We know that we can control the process by influencing various steps along the biosynthetic pathway. Perhaps the best studied step involves that of the tyrosinase enzyme. For years, scientists have been looking for ways to regulate this enzyme and therefore slow melanin formation. One can regulate tyrosinase by either slowing down its activity or competing for its substrates, either tyrosinase in step 1 or L-DOPA in step 2. An example of a mechanism that controls tyrosinase activity would be the use of rice extract. The phytic acid that is found in rice binds the copper metal ions, slowing down 2 of the tyrosinase-mediated reactions. In the past few years, the list of agents that bind copper and help control pigment formation has been expanded to include many ingredients, such as kojic acid and aspergillus ferment, a fungal extract. There's also rumex extract, commonly known as yellow dock plant, and ergothioneine, a plant amino acid. We even have gluconic acid and zinc glycinate. All of these can inhibit the tyrosinase enzyme. There are many botanical extracts that have been studied for their ability to inhibit the enzyme as well. These include kiwi fruit extract, or rumex, known as yellow dock, Phyllanthus emblica fruit extract, nasturtium, the common flower that you may see in your garden, even mulberry and bearberry, as well as licorice and Ferula foetida, the giant fennel plant extract. All of these plant extracts are believed to contain an active agent that competes with tyrosine, the amino acid, for the tyrosinase enzyme's attention, but not being the real thing, they don't result in melanin formation. This process is known as competitive inhibition. While the use of hydroxyacids in skin brightening products has generally been utilized to accelerate desquamation or the removal of pigmented keratinocytes, it's recently been shown that a 5% concentration of lactic acid will inhibit the formation of the tyrosinase enzyme, thereby slowing down the process of melanin synthesis. This new approach to affecting melanin synthesis is unique to lactic acid and does not occur with the other hydroxyacids such as glycolic acid or the beta-hydroxyacid salicylic acid. Other exfoliating agents used in brightening products include pumpkin enzyme or lactobacillus ferment and a galacto-arabian, a molecule that stimulates your skin's natural desquamation. Another means to control hyperpigmentation is to control inflammation. The use of anti-inflammatory agents such as licorice extract or green tea with its polyphenols and white tea and mulberry will all help to address the connection between inflammation and pigment formation. These extracts also may act as antioxidants, slowing many of the oxidative steps involved in melanogenesis. More recently, scientists have demonstrated other potential points in the pathway that can control melanin formation. Niacinamide stops the transfer of melanosomes to the neighboring keratinocytes, while glucosamine stops the activation of the tyrosinase enzyme, a required step before melanin synthesis can even occur. The more familiar ascorbic acid, or vitamin C, has been used for years to control melanin formation. But newer, stabilized derivatives of vitamin C, including my favorite magnesium ascorbyl phosphate, or MAP, and ascorbyl glucoside, and tetrahexyldecyl ascorbate, are all used to control melanogenesis now. These derivatives can scavenge free radicals that cause erratic melanocyte activity, as well as act as antioxidants, inhibiting oxidation steps in the formation of melanin. More recently, peptides have been investigated for their ability to control pigmentation. Oligopeptide 34 is a state-of-the-art peptide that has been shown to inhibit tyrosinase activity. While the mechanism is not clearly understood, results indicate that it brightens the skin, especially sun-induced hyperpigmentation, in half the time compared to other brightening complexes. So you can see, we have evolved beyond just controlling steps 1 and 2 in melanin formation. In summary, we have numerous options that we can target to get effective control over hyperpigmentation. From impacting the initial signaling to make melanin, the well-studied steps 1 and 2, to the lesser-known oxidative steps, and even the transfer of melanosomes to keratinocyte cells, all of these are potential targets in controlling pigmentation in the skin. The first step, as with any skin treatment, is the consultation card. Determine what your client's main concerns are, and then the possible causes. Take a complete history to determine medications, hormonal influences, stress levels, product uses, etc. Start with a skin analysis. Not all of the client's pigmentation may be visible on the surface of the skin. A Woods lamp that emits UV light or skin scanner can come in handy for not only you, but even your client to see and understand what may possibly come to the surface. A Woods lamp can be used to determine the depth of melanin in the skin. The variations in epidermal pigmentation become more apparent under a Woods light. For dermal pigmentation, the contrast is less pronounced and is a good indicator that the pigmentation is going to be more difficult to treat. Exfoliation is one of the most important steps in treating hyperpigmentation, especially when we utilize lactic acid at a 5% concentration or higher. Exfoliation helps slough the layers of keratinocytes that contain the excess melanin pigment. When doing the professional treatment, consider the use of electrical equipment to drive active ingredients down to the melanocyte at the base of the epidermis. Ultrasonic, galvanic iontophoresis or microcurrent, and specific iontophoresis can all be used over a complex or serum that helps deliver the active ingredients further into the skin. Above all, we need to be realistic with the results we can achieve on our clients, which means proper prescription of appropriate products for at-home use. It's important that you work closely with the client, keep them motivated and dedicated to their skincare regimen. This may include a series of professional treatments once a week for 6 weeks to get them started. Regardless of which brightening agents one selects for treating hyperpigmentation, the key thing is to remember that they must be consistent in using the product every morning and night for at least 8 weeks before you will detect an improvement. Even if you could shut down all new melanin biosynthesis in the skin, remember it still takes about 45 days for the cells with melanin to naturally slough off our skin. At the same time you're treating existing hyperpigmentation, you must use a minimum SPF 30 on the skin whenever outdoors. Too often, someone is religious about application of his or her pigment lightener and brightening products, but then they forget to apply a sunscreen, and within 24 hours, the hyperpigmentation spots can reappear. Remember, the depth of the pigmentation will dictate the degree of effectiveness when treating hyperpigmentation. Dermal pigmentation is obviously more difficult to treat than epidermal pigment. For obvious reasons, hormonally induced pigmentation and deeper post-inflammatory hyperpigmentation are even more difficult to treat. The easiest to treat is, of course, the sun-induced hyperpigmentation. And remember, you and your client should have realistic expectations as to the degree of lightening that you will achieve. It's highly unlikely that you will make a spot disappear, but you can reduce its intensity and help to even out the overall pigmentation of the skin. Not all hyperpigmentation spots will respond favorably. If 75% of your clients get significant lightening to hyperpigmentation, that's considered a very good result. Thank you for joining us for today's webisode on understanding and treating hyperpigmentation. For a copy of today's notes, please fill out the short survey on the link provided. For more information on the topic of pigmentation, please visit us at dermalinstitute.com.